If you have rough, textured bumps on the backs of your arms or thighs, you know the frustration of strawberry skin. You have likely spent significant time and money on heavily marketed scrubs and lotions, all promising a final, flawless cure. Despite these claims, the physical reality of the skin's structure presents a much more persistent challenge than a single bottle of product can address. To manage it, we first have to clarify what it actually is. Keratosis pilaris, or KP, is not a bacterial infection. It is not a contagious disease, and it is certainly not a result of poor hygiene. This chart shows the sheer scale of the condition. Keratosis pilaris affects between 50 and 70% of all teenagers and remains active in roughly 40% of the adult population. It is a chronic structural feature of the skin. The way the skin builds and sheds itself is dictated entirely by a person's DNA. Keratosis pilaris is an autosomal dominant trait. If you have it, your skin's structural behavior is hardwired into your genetics. Attempting to fight your genetic programming with superficial cosmetic scrubs is a losing battle. The physical friction cannot alter the instructions your DNA is sending to your skin cells. To stop wasting money on false cures, we have to look at the exact microscopic histology of the skin. We need to see how the pore functions on a cellular level. We will deconstruct exactly how to chemically dissolve these bumps and evaluate the clinical evidence for specific targeted acids and laser therapies. Managing this condition requires a mental shift. You must stop acting as a beauty consumer chasing trends and start applying a clinical biological understanding of your own skin barrier. Keratin is a normal essential protein. It forms the tough outer layer of the epidermis, protecting healthy skin from environmental damage and infection. In KP-prone skin, a specific anomaly occurs. The body overproduces this protective protein and clumps it together, rather than allowing the dead skin cells to flake off and shed naturally. In dermatology, this localized overproduction of protein is called hyperkeratosis. This 3D cross-section shows hyperkeratosis. Excess keratin accumulates into a dense plug capping the follicle. Acting like a cork, it traps the growing hair, forcing it to coil beneath the surface. The body detects this disruption, triggering localized inflammation around the follicle. This microscopic inflammation is the direct cause of the symptoms you see in the mirror. The immune response creates the white dots, known as erythema, and the keratin cap creates the rough, sandpaper-like texture. Environmental factors heavily impact this biological structure. The severity of keratosis pilaris is not static year-round. During the winter months, cold, dry air strips necessary moisture away from the skin's lipid barrier. Without environmental moisture, the already dense keratin plug dries out and hardens even further, making the rough texture much more pronounced. Because this blockage is a tightly bound structural protein plug, superficial topical creams cannot wash it away. The plug must be actively and chemically dissolved. The instinctual reaction to rough skin is to reach for a loofah or a heavy sugar scrub to forcefully sand the bumps away. Violent physical scrubbing induces immediate microtrauma to a hair follicle that is already in an inflamed, defensive state. This microtrauma forces the immune system to react further, worsening the redness and frequently triggering hyperpigmentation, which leaves dark brown spots long after the inflammation subsides. Dermatologists mandate a dual-action approach for KP: hydration to repair the barrier, and keratosis, the specific chemical dissolving of keratin. The clinical gold standard ingredient that fulfills both of these requirements simultaneously is urea. Urea's first biological function is as a humectant. It actively pulls necessary water deep into the dry skin barrier to hydrate the surrounding tissue. Its second biological function is as a keralytic. Urea acts like molecular scissors, actively breaking down the chemical bonds that hold the hard protein plug together. This dosage chart shows how urea concentration dictates its function. At 10%, it operates mainly for daily maintenance hydration. To achieve targeted, active keralytic action on thick, stub-on bumps, a much higher concentration of 20 to 30% urea is required. Chemical peels provide an alternative or supplementary keralytic. The most effective options are alpha-hydroxy acids, like lactic acid, and beta-hydroxy acids, like salicylic acid. Salicylic acid has a distinct biological advantage. It is oil-soluble, allowing it to penetrate deep inside the lipid-rich blocked pore to dissolve the keratin trapping the hair. Mild AHA and BHA lotions can be used for daily home maintenance, while deeper, controlled chemical peels require administration by a dermatologist for severe cases. Effectively treating keratosis pilaris means replacing the brute force of mechanical destruction with the precision of chemical deconstruction. This brings us to a major exacerbating factor for female KP patients: hair removal on the legs and arms. Traditional shaving has a severe biological impact on a blocked raised follicle. As the razor glides over the skin, the blade physically slices the top of the raised keratin bump. This causes microbleeding and eventual microscarring across the limb. Laxing and epilation are equally damaging. Violently ripping a hair out of a constricted, plugged pore inflicts severe trauma on the follicle structure. These traditional hair removal methods guarantee an endless cycle of folliculitis, severe inflammation of the hair follicles, and darker, deeper ingrown hairs. The critical recommendation for hair removal on KP-prone skin is laser hair removal, utilizing specific wavelengths like diode or ND-YAG lasers. The physical mechanism of the laser bypasses the skin entirely. It passes harmlessly through the surface to selectively heat and destroy the hair root beneath. By permanently destroying the hair follicle, the root cause of the ingrown hair cycle is eliminated completely. Without a hair shaft present, there is no longer a physical scaffold for the keratin plug to form around. The bump effectively flattens out. For KP patients, laser hair removal functions as a structural intervention, removing the root cause of the continuous inflammation. With the biology deconstructed, we can establish an optimal, evidence-based clinical protocol for daily management. Step 1. Gentle cleansing. Avoid harsh physical abrasives entirely to protect the skin's delicate moisture barrier. Step 2. If accessible, integrate laser hair removal into your long-term plan to permanently alter the follicular structure and eliminate the keratin scaffold. Step 3. The consistent application of urea or acid-based keratolytic lotions to actively dissolve the protein plugs. Step 3 comes with a strict timing constraint. These lotions must be applied within 5 minutes of stepping out of the shower. The skin must still be damp. This allows the active ingredients to effectively lock in the humectant hydration while softening the hardened keratin bumps. Because keratosis pilaris is an autosomal dominant genetic trait, consistency is the only functional intervention available. If the chemical exfoliation and hydration routine stops, your genetic programming will immediately resume its normal function. The keratin will build up and plug the pore all over again. Managing KP requires abandoning the search for a heavily advertised miracle cure and adopting a scientifically backed, sustainable routine. Understanding the histology and chemistry of your skin gives you autonomy, allowing you to make precise, effective choices in a crowded skincare market. Mastering the continuous biological management of your own genetics provides the most effective path toward clear, healthy skin.